Okay, so this is tar JJ. This is an important tar for almost all of you. There's very, very few, if any of you guys, that actually have this tar. I know we had started on it right before we let out for the break, so there are several of you that may remember this information. However, you've not taken your tar evaluation yet, so you've not been checked off on it. If you can make sure that you do that when we're through with this video, then we'll get you signed off as soon as possible. To hear their quote, he who makes a beast out of himself gets rid of the pain of being a man. So just think about that for a minute. If you are hurting and you're angry and you want to get rid of that, you can, but then you won't have the joy or anything else that goes along with being compassionate and being human, being empathetic. So that's really what he's talking about. He's not really talking about being a beast. He's talking about the figurative use of the word man and the figurative use of the word beast. It's kind of deep when you think about it. All right, recognizing and describing the common approaching signs of death. Why is that important? Well, as a CNA, you're going to spend more time with the patient than anyone else will. So if you notice those signs first, then you may have given us the opportunity to call the family and let them be with them at their loved one's last minute. So what are some signs that you can think of? I know you guys can't respond to me right now, so I'm just going to go ahead with the next slide on that one. Should you report these signs to the nurse? Absolutely. Should you tell the family what these signs are? I probably wouldn't. That's going to get them more upset. Now, if they ask you, don't lie to them, but I wouldn't just point out, oh no, they're turning mottled or their respirations are declining. I wouldn't point that out to them because you don't want to make them upset. However, if they ask, please don't lie to them. Approaching death signs. This is from page 405. This is going to be blurred vision, failing vision, impaired speech, diminished sense of touch, loss of movement, muscle tone and feeling, a rise or below normal body temperature. And we're not talking about a little bit, we're talking about a whole lot, a big difference. Decreasing in blood pressure, again, not just a little bit. I'm talking maybe 60s over 40s or 60s over 30s, or it may be so low on your automatic cuff it may not even read. A weak pulse that's abnormally slow or rapid, again, the same thing there. It's not going to be just a little bit off. We're not talking 120, we're talking like 170, 180 rapid. Or when it says slow, it may be like 30 or 40, not just 50 or 60, okay? It's not going to be just a little slow. It's going to be a whole lot slow. You're going to definitely know the difference when you see that. And alternating periods of slow irregular respirations and rapid slow respirations, these are called Cheney-Stokes respirations. A rattling or gurgling sound as the person breathes. This is often called a death rattle. That's kind of hospital slang, but that is something that you will hear when somebody is saying, oh, they've got the rattle, or they may ask you, are they rattling yet? This is what they're talking about. And it's very unique. Once you hear it, you'll never forget it. They're going to have cold, pale skin. They may have a mottling appearance, which kind of looks like they're bruised, but it's going to be all over or splotchy. It's not going to be just in one certain area like a bruise would. Sweat and incontinence. They may lose control of their bowels and of their urine. They may be confused or disoriented. And then again, they may be in that stupor stage where they're not able to respond to you or look at anything already, which is definitely a sign of approaching death. Okay, so this is our video here. This is going to be normal breathing, tachypnea, and the Biots, Cheney-Stokes, Kussmaul's, and the bradypnea. See if I can get this to play here for you. Okay, so it doesn't look like I can play the link when I'm actually doing a recording, so I will post these links separately for you guys so that y'all can go back and watch them. They will be available for you, though. I apologize for not being able to do it in the lecture, but for some reason I can't when I'm recording. I can, however, if we were in class. So we'll just go back and put that in a separate area for you guys to watch. It'll be under your videos. And this one is going to be the death rattle. Again, I'll post that one for you also. Alright, here's an example of that modeling skin. You can see where it's discolored throughout the whole arm. Alright, why do you want to have palliative care? First off, what is palliative care? The goals of palliative care are going to be comfort and dignity. It basically means you're just going to keep these people comfortable for as long as possible. The focus is going to be on pain relief. Residents who are dying need to feel independent as long as possible. Okay, so eventually you may have to meet all of their needs. This doesn't mean doing everything for them to start with. This means letting them do it as long as they can, but when they're not able to, at that point, then you start taking care of all of their needs for them. All right, the 5 stages of grief, they're going to be denial, anger, bargaining, depression, and acceptance. Grief does not always go through those stages. It will if it has time, but sometimes it doesn't have all time to go through all 5 of those. A person may not go through them in that order, and it's important to know what stage a person is in when providing care for them, because the stages differ than the process. So basically, if somebody is in their anger phase, they're going to lash out at you. And if you are aware that they're grieving, then the way that you respond to them might be different than if you think they're just an angry person. And the same is true with that depression. If they're talking about they would rather just go ahead and take themselves out, and you know that they're already dying, you may not view that the same as you would if they have no underlying disease or nothing that would cause them to die. And the acceptance phase, guys, that is a really strange one to experience, because at this point, they know they've accepted it, and sometimes they may be a little happy. They may greet you when you come in their room, and they may say, "Oh, guess what, Miss Jones? I picked out my headstone. Come here, you gotta look at it." And they get all excited and they want to show you. It's kind of strange to experience as a caregiver. However, that is one of the stages they go through. You also need to know the grief process, which is shock, denial, anger, guilt, regret, sadness, and loneliness. Family and loved ones go through this process, and no 2 people are going to grieve the same. It's a changing and adaptive process constantly, and sometimes you may go back and forth before you ever move on. The shock is usually the first one, but it's not always going to be the same with everybody. Denial is another one. I've seen that one too. And it's a hard one to experience also, because they're going to tell you, no, they're not dead. No, you're wrong. They're just holding their breath. Or they may look at it as, no, they're just breathing too shallow. You just can't see it. But you're wrong. They're not dead. You have to be patient with these people. You have to give them the time that they need. The same is true with anger and guilt and regret, sadness, loneliness. All of those are going to affect people differently, and it's important to give them the space and the time that they need to deal with that. And you may experience it also because you're the caregiver, and sometimes when you're in long term, you have the same patient for months and months. So when that happens, you may get attached to them, so you may have that process as well to go through. All right, attitude and belief toward death. This is influenced by many factors, such as your experience with death, your personality type, religious beliefs, and cultural background. Now, when I say experience with death, if you have worked in healthcare a long time, sometimes we kind of get a little jaded toward that. It's not a good thing. We should be more emotional, but sometimes as a defense mechanism for ourselves, to keep ourselves from having to go through that over and over and over and over again, we tend to build up a little brick wall. And when that happens, it's easier for us to deal with death, but it may be harder for us to deal with the family members that's experiencing that death in that family. Your personality type has another big influence. your religious belief, because not everybody believes that you go to heaven and not everybody believes you go to hell. And that can be both a strength and that can be a weakness depending on how you view it. Your cultural background, again, would have a huge influence in that. Here in the South, we're more family oriented, which I don't mean that other places are not. What I mean by that is when one person has a death, the entire family may bring food. They may bring whatever. They may bring money. They may bring flowers to keep the person that's immediate from having to do anything such as cleaning or cooking around the house. All they want them to have to do is grieve. And that may be a little different depending on where you live at. It just depends on all of those factors when you're looking at what your belief and your attitude is going to be. So strengths and coping mechanisms, this is from pages 399 to 400. Your strengths, coping mechanisms could be things such as clergy, counselors, or social workers. They can provide help for people that are grieving. Religion, we had talked about earlier that it could be both a strength and a weakness. For an example I used was heaven or hell. If you believe in heaven and you know that your loved one was a very kind, generous soul, that may be a strength for you because you may not feel as bad about them dying. The same could be true as a weakness. If you believe in hell and you know that there was not the best person on the face of the planet, then that could be a weakness as far as your grief process goes, because you may be upset about them dying. I'm not saying either one is a strength or a weakness. I'm just saying it could be either or depending on how you view it. A positive coping mechanism would be something like a support group or a hobby of any sort, whether it be fishing or exercising, just something to get your mind more active and away from the subject that you're grieving. Comfort care for the individual. This is from pages 400 to 401. You need to follow specific care plans per patient. Those are going to vary very greatly depending on what they have exactly going on. You need to follow general guidelines, respect them, respect their family, give them time alone if they ask for it, treat them as an individual, not as just a number. Don't avoid them. Don't avoid their family. Don't deny the death. When the family says, I think they're dying, don't be like, oh, no. Do not tell the resident that anyone knows how or when it will happen. In other words, don't say, they should be passed by tonight, or I don't think they'll make it through the night. And always honor their rights. General guidelines for that would be if they have diminished senses, hearing is usually the last to leave the body. So if they can't see, you would want to make sure you tell them before you touch them. Don't expect them to respond to you, but don't just grab their arm and move it without telling them what you're fixing to do. Because imagine yourself in their position. If you're laying there and you can't see anything and all of a sudden something grabs your arm, it's going to scare you, right? Well, the same thing is going to be true for these patients. It's going to scare them as well. So make sure that you tell them what you're going to do, even if they can't respond to you. Take care of their mouth and nose. Very often in the unconscious patient, you want to do it every 2 hours because the lips get real dry and they start cracking. So you'll make sure you use lip balm. Make sure it's not a petroleum-based lip balm, however, if the patient is on oxygen. Skin care, bed bath, and incontinent care is needed. Keep your sheets wrinkle-free. Wrinkles can actually increase the risk of pressure sores, which of course would be uncomfortable. And our goal here is comfort. Pain relief is critical. So position, back massages, and skin care, mouth care, body alignments, all that may help with pain relief. Keep in mind though, they do still have rights to refuse. If you go in to turn your patient and they say, no, I don't want to be turned right now, you can't turn them. That's their right. They have every right to tell you no. The environment should be comforting to them. So they should have their family members where they can see them, play music if they like music, keep the room appropriately lit. In other words, you don't want it to be too dark to where they can't see. However, if light is bothering them, they may want it dimmed. A call light within the reach, even if they're unaware of their surroundings. It's a comfort thing for them. Emotional and spiritual support, you want to listen. That's the most important thing you can do when it comes to supporting them emotionally at this point. It's just listening to their concerns. there's not really anything you can do to change it. However, if they just have somebody to talk to, sometimes that is enough to make them feel better. Their dying rights would be the right to refuse treatment, the rights to have visitors, the rights to privacy, and the dying person's Bill of Rights, which I'm going to read right now for you. And it's, I have the right to be treated as a living human being until I die, maintain a sense of hopefulness, however changing its focus may be, being cared for by those who can maintain a sense of hopefulness, however changing this might be, express my feelings and emotions about my approaching death in my own way, participate in decisions concerning my care, expect continuing medical and nursing attentions, even though cure goals must be changed to comfort goals, not die alone, be free from pain, have my questions answered honestly, not be deceived, have help for my family in accepting my death, die in peace and dignity, retain my individuality, and not be judged for my decisions, which may be contrary to the beliefs of others, discuss and enlarge my religious and or spiritual experiences, whatever these may mean to others. Expect the sanctity of the human body will be respected after my death. Be cared for by caring, sensitive, knowledgeable people who will attempt to understand my needs and will be able to gain some satisfaction in helping me face my death. Okay, so basically, you're going to treat them how you would want to be treated if you were going to die. You want to be respected, and so do they. Comfort care for the family and loved ones. Speak to them when you enter the room. Also, don't avoid them. If the resident has left a legal document outlining the death, it's up to the resident, not the family. But you have to be respectful in letting them know. And if it's a situation you don't feel comfortable with, you may need to call the nurse or the doctor to handle a family that might be upset. An example of this would be a family member says they're going to call the funeral home for a burial, and your patient has requested to be an organ donor, and there may be a different process that needs to go through for them to be an organ donor before the funeral home comes to get them. That would be a situation where you would say, well, let me go get your nurse real quick, because right now that varies by hospital policy, it varies by organ donation bank. There is a process, and not everybody qualifies for that, so that's something that has to be investigated. Another example would be if a patient says, I don't want to be a full code, I want to be a DNR, I don't want to be resuscitated, when I die, I want to die. And you have a document that backs that up, and the patient starts to die, and the family says, oh no, you need to save them, you need to save them, you need to save them. You cannot. You have to respect that resident's wishes. If they become upset with you, then you need to go get the nurse or the doctor so that they can explain it more to the patient and the family, if the patient's not able to communicate that themselves. But always remember, your patient is your boss. You work for your patient. You do not work for the family. And sometimes that's a very fine line, because you still have to treat these family members with respect also. Hospice care is a term for special care that a dying person needs. It uses a holistic approach. It treats physical, emotional, spiritual, and social needs. It is 24/7 care. You are on call every minute of every day and night when you're a hospice care person. It's with a doctor's order. The goals are comfort and dignity. The guidelines are to be a good listener, respect privacy and independence, be sensitive to individual needs, be aware of your own feelings, recognize the stress, and take good care of yourself. The postmortem care is care of the body after death. You're going to follow those guidelines. You're going to be aware of religious and cultural practices. Only perform assigned tasks to you. That is very, very important. Make sure that you're not doing anything outside of your scope of practice. If a resident is an organ donor, the NA should follow the nurse's instructions. There may be tasks specific to organ donation. This is very, very true. And we have orders that we have to follow that come from the organ bank, and we have to call them within a certain time of death, which is another reason it's important that you make sure you report that immediately when you see those declining signs. Postmortem care guidelines. You may need help if the body becomes rigid, which is stiff. You can bathe the body. Do not remove any tubes or equipment. Replace the dentures in the mouth or place them in a cup beside the bed. Close the mouth and eyes. Position the body on the back with the legs straight and arms folded across the abdomen. This is important, guys. Please don't leave them sitting in a sitting position, because if you don't lay them flat, or at least almost flat, it's going to be very hard for the funeral homes to get these people in the caskets afterward, if they're going to be in a casket, because they have that rigor mortis that sits in and they're stiff. You do not want your resident to end up with broken bones from people attempting to get them in a casket because you did not put them in the proper position after they die. So it's really important that you make sure that you do that. Now, if there is a different request of any sort, then that would be an exception. You may need to get the nurse or the doctor or the facilities, whoever is in charge at that point. But as a general guideline, you put the patient on the back with the legs straight and the arms folded across the abdomen. And if you're going to recline them at all, it's going to be very, very little. Most of the time, they want them flat. Follow the facility's procedures on personal items. If you have to give Mama a ring back to her daughter, make sure you have a witness. You do not want to be the one that family member comes back and says, they didn't give me that ring. Especially not if the ring is real, because at that point you could be looking at a couple $1,000s, and you're going to have to probably face legal charges at that point of some sort. Maybe not, but it's possible, because they're going to say it's theft. And if you have no way of proving it, it could be an issue. So make sure you always have a witness with you. After you remove the body, you're going to strip the bed, open the windows to air the room out, and straighten it up. Document according to your facility's policy. Emotional responses to death, those are talking about your responses. You're going to grieve. Like I mentioned earlier, you're going to be caring for these people for a long time. You may be attached to them. So you need to allow yourself that time to grieve. Check with your supervisor, though, before you attend any services, because that's kind of breaching that line of professional and personal. You have to make sure that it's okay for you to do so. Recognize the need for emotional breaks and the stress in your mind and body, and develop coping mechanisms that you can deal with those situations as they arrive. And here are your references there.